Hello everyone. Topic for today's class is inherited disorders of amino acid metabolism. This topic might appear a little boring, but this topic is important because many questions are there in your entrance exams from this topic, as well as these diseases may be rare uh, as per individual distinct diseases, but as a group of diseases, it is quite common. You can see one case in 5,000 of patients. I'm Dr. Devender Bairwa. I have done my DM in Immunology and Rheumatology from JIPMER. Previously, I was SR in Rheumatology in AIMS Delhi. I did my MD Medicine from AIMS Delhi and MBBS from MC. We will be discussing this topic under following headings. First, we will see some clinical scenarios pertaining to the topic. Then we will have little introduction to amino acids. Then we will briefly discuss some clinically important disorders, including hyperphenylalaninemia, Homocystinuria, Alkaptonuria. And the last, we will conclude the topic with seeing some defects of urea cycle. So let's see some clinical scenarios. Suppose if someone is on phenylalanine restricted diet as its treatment for phenylketonuria, then which amino acid becomes essential? Options are A. Isoleucine, B. Valine, C. Tryptophan, or D. Tyrosine. The other question is, classic urea cyclic defects are associated with the increased plasma level of which amino acid? Options are A. Glutamine, B. Ornithine, C. Citrulline, D. Arginine. Folate trap means that folate also becomes deficient once B12 is deficient. Option B, B12 also becomes deficient when folate is deficient. Option C, folate becomes excessive when B12 is deficient. Or option D, B12 becomes excessive when folate is deficient. Next question. Previously completely healthy 30 years old male had 2 discrete episodes of acute onset of coma with findings of hyperammonemia and elevated plasma glutamine levels. The first time he had steak and the second time he had fish prior to the episode. His father and one paternal uncle also have a history of similar kind of illness, but they both died of liver failure. Most likely this patient is having A. Citrulline deficiency, B. Ornithine transcarbamylase deficiency, C. Phenylketonuria, or D. N-acetyl glutamate synthase deficiency. So throughout this presentation, try to find answers for these problems. Now let's start introduction to amino acids. So as the name suggests, it is an acid. It has to have some tendency to give a hydrogen ion. And because the name also contains amino, that means there is an amine group attached. So this is a basic structure of amino acid. As you can see, there is one amino group, is NH3. Then there is a variant group known as R group. Then there is a carboxyl side chain, COOH. This H ion is released by this amino acid. That's how it behaves like an acid. And there is no hydrogen. So basically, it's a structure of methane. But this CH4, this H is preserved. Then these 3 H have been replaced. This H is replaced by a carboxyl group, making it an acid. And then there is replacement of one H with the NH3 group, making it an amino. And there's an R group, which is variant. On the basis of this R group, we can divide these amino acids into different types of classes. As such, total number of amino acids in the body is 20. Let's see their basic structure and classification according to the R group. There can be aliphatic side chain. This group contains glycine, alanine, valine, leucine, and isoleucine. The message that you should take from this table is that only their name, their symbols, and a rough idea about structure. You are not supposed to remember their pK values. You are not supposed to remember their complete structure formula, but you should have idea that these amino acids are having variable R group. For example, see the glycine. Glycine has only H, smallest group. That means glycine is the amino acid which is the smallest size, and it will lead to less hindrance. That's why in collagen you have glycine there. Then similarly, alanine has a methyl group. Then valine has isopropyl group. Then leucine has isobutyl group, and so. Leucine, isoleucine have It has different structure, but the overall molecular weight is same. That's why leucine and isoleucine name is similar. Coming to hydroxyl group containing and sulfur group containing amino acids, serine, threonine, and tyrosine. These three are the amino acids which are contained in one hydroxyl group, and cysteine and methionine are two amino acids which are containing sulfur groups. Coming to acidic group containing amino acids, aspartic acid and its amine aspargine. Similarly, glutamic acid and its amine is glutamine. These four are considered under acidic group of amino acids. Then we have basic groups. We have three amino acids, arginine, lysine, and histidine. We can see they have big side chain. Along with in the side chain, they're having lots of nitrogen amine. This makes it a basic chemical. Then coming to aromatic and imino group, we can see that histidine, which was discussed with hydroxyl group also, phenylalanine, tyrosine, tryptophan, all these are aromatic amino acids. You can see they are all having a benzene ring in their structure. And proline is not a true amino acid, but in fact it is the amino acid because it does not contain a amino group. And this is the structure of proline. So we have total 20 amino acids in the body, and they are the building blocks for all the proteins made up in the body. So there's a concept of essential amino acids and non-essential amino acids. The term itself is a misnomer because if you see all 20 amino acids are actually essential for protein synthesis. It is just that some of them can be manufactured in the body itself, some cannot be. Those which cannot be manufactured in the body has to be present in diet, and that's how they become nutritionally essential. If you see in this list, there are 10 names mentioned in this nutritionally essential list. This table has been taken from Harper. Your Harrison is mentioning that there are 8 essential amino acids, but in fact, there are 10 nutritionally essential amino acids. Harry mentions 8, but in the bracket, it has given name of 9 amino acids, so it is a mistake. So arginine is something which is actually semi-essential. That means in kids, infants, and children, arginine cannot be synthesized, but in adults, it can be synthesized. So it makes arginine a semi-essential amino acid. Apart from that, histidine, isoleucine, leucine, lysine, methionine, phenylalanine, threonine, tryptophan, and valine, all these are nutritionally essential and should be present in adequate amount in your diet. When there are specific defects of biosynthesis of these any of these amino acids, then depending on particular defect, there can be change in this essential requirement. For example, if there is a defect in phenylalanine pathway formation, then tyrosine can become essential because we know that phenylalanine is actually a precursor for tyrosine formation. So suppose if somebody is not able to form this amino acid, then mostly it will not form. Okay, so what are the main functions of amino acids? If we see, they are building blocks for peptide and protein. This is their main function. Apart from this function, amino acids do serve other roles in the body, including they can serve as neurotransmitter. We all know glutamate is an excitatory neurotransmitter. Then glycine is there, GABA is there. Glycine and GABA both are neuroinhibitory transmitters present in your brain. Then they are also precursor of hormones, coenzymes, pigments, purines, or pyruvatides. So the essence is that if there is defect in amino acids, then their defect can lead to varied manifestation. And when there is severe deficiency, it can be lethal because the defect can be either partial, complete, incomplete, partial. So in such a way that manifestation can be either very asymptomatic or very symptomatic, or there can be a mixed picture. So coming to inherited disorders of amino acids, if we see individually these diseases, they are rare, like phenylketonuria, cystinuria, their frequency is 1 in 10,000 of newborns. And homocystinuria or alkaptonuria are also very rare, 1 in 2 lakh population. But when collectively we see these all disorders of amino acid, then their frequency is 1 in 1,000 newborns. That means 1 out of 1,000 children might be having any of these defects. Almost all these disorders, they're transmitted as autosomal recessive traits, but there are some exceptions for that thing. You will see that in subsequent slides. You can divide these disorders broadly into amino histopathies or you can divide them as organic acidemias. Now remember, because amino acid is the acid, when it is handled in the body, when it is broken down into substrates in the body, obviously one acid will produce acid only. So in case of amino acidopathies, there is defect which lead to excess of parent amino acid in the body. In case of organic acidemias, there is accumulation of products in catabolic pathways. And how to name them? So suppose if there is increase of one particular amino acid in the body, then emia is taken as a suffix to the name. Suppose substrate is the name of amino acid, then if it is increased because of defect in some metabolic pathway, then the name that can be given is substrate emia. Similarly, when these amino acids they will increase blood, that will lead to more excretion of these substances in urine, leading to urea. So substrate urea. Suppose if substrate is high in the body, then it will be in the body, in the body from the body into urine. Then you can call it substrate urea. So basic defect is basically what we are doing. Basically accumulation of particular substrate mostly, but not all. Proximal to irreversible enzyme step will be there. So what happens? We all know these amino acids, they will undergo reactions, subsequent reactions, 4-5 reactions, ultimately forming an end product. Many of the enzymes, they are reversible, bidirectional. So wherever the enzyme is only unidirectional or rate limiting, if that step is blocked, then the substrate which was proximal to the reaction will accumulate in the body, causing increased level of that substance in the body, as well as increased excretion of same thing into the urine. These tables are taken from Harrison. Table is vast, difficult to remember. We don't expect you to remember everything. The most important parts I have already highlighted. I would like you to notice these changes, these things. So let's say phenylalanine, we know that phenylalanine is an acid, and there are various kind of defects in this condition. Phenylketonuria, we will discuss subsequently in detail. It is because of deficiency of phenylalanine hydroxylase, and this condition has typical mousy odor because of the substrate collection. Then in tyrosine type 1 is there, type 2 is there, type 1 is more lethal, and it is also known as hepatorenal form, and this is associated with a boiled cabbage odor. Tyrosine type 2 is oculocutaneous, less severe, and it is associated with palmoplantar keratosis, painful corneal erosions with photophobia and learning disabilities. Then there is Alkaptonuria, that is because of defect in homogentic acid oxidase. The important point associated with Alkaptonuria is that this was the first disease of inborn error of metabolism, which was described by Sir Archibald Garrod at that time. Then there is albinism, which can be oculocutaneous form only. It is because of deficiency in tyrosinase enzyme, and this presents with hyperpigmentation of hair, skin, and optic fundus, visual loss, and photophobia. Now, see this, all these disorders are autosomal recessive, but this Hawkinsinuria is actually autosomal dominant. This is the only condition which is having different kind of inheritance pattern. Then you can see this albinism, ocular albinism is there. This is because defects in of different enzymes or transporters. And this presents with hyperpigmentation of optic fundus or visual loss. This is associated with the X-linked inheritance. Coming to GABA, tryptophan, histidine, nothing is important in this as far as your questions are concerned. In case of your glycine, you can see sarcosinemia is there. I have highlighted this because I wanted to show that many of the defects can be very, very benign. Sarcosinemia has not been associated with any kind of clinical manifestations. Then there we have hyperoxaluria type 1 and hyperoxaluria type 2. So basically this glycine, when is getting metabolized in one of the in these steps, somewhere intermediate that is being formed is oxalate, and when defect is there, this oxalate can increase, leading to oxaluria. In case of type 1 and type 2 both, you have calcium oxalate nephrolithiasis, as well as in long term they can develop renal failures. Diseases associated with serine are not important as far as exam is concerned. I have highlighted this prolidase deficiency because of deficiency in enzyme of prolidase, which lead to high levels of proline, which actually present with mild intellectual disability and chronic hepatitis. As a rheumatologist, I can tell I have seen many patients of prolidase deficiency whose clinical picture actually appears like SLE patients. Then there is methionine, and then homocysteine. Homocysteine is important because homocystinuria, as we all know, they present with Marfanoid habitus, thrombotic vascular diseases, then less dislocation, as well as increased risk of cardiovascular as well as cerebrovascular diseases. Total, there are 9 kinds of homocystinuria. As we can see, one form is associated with cystathionine beta synthase. This is the classical form of homocystinuria. Apart from that, then there are 5 deficiency of 5-10-methylene tetrahydrofolate reductase, methionine synthase, and vitamin B12 lysosomal efflux and metabolism, including these molecules. So if you count them 1, 2, 3, 4, 5, 6, 7, 8, 9. In total, there are 9 different types of homocystinuria. Classical disease presents with all these features which I discussed, and other forms they present with intellectual disability or gait problems, psychiatric abnormalities, or megalologic anemia. Then cystathionine is there. Cystathionuria can occur because of deficiency of beta cystathioninase, but I have marked it because it is also a benign condition. Then coming to cystinosis. Cystinosis actually we have discussed in the previous class. If you remember, we have discussed is as an example of disorder associated with membrane transport. Cystine gets accumulated in your lysosome because efflux is defective. It leads to renal Fanconi syndrome, rickets, photophobia, hypotonia, and renal failure. Then let's focus on lysine and tryptophan metabolism. Glutaric acidemia type 2. The beauty of this disease is that this peculiar sweaty feet odor associated with the disease. Then there is ornithine deficiency. It presents with gyrate atrophy of the choroidal retina. This is an MCQ which have been frequently asked. Then coming to urea cycle, we can see that in urea cycle defects, there are so many enzymes in urea cycle. We'll discuss that subsequently further. But in all the diseases of urea cycle, lethargy, progression to coma, protein aversion, intellectual disability, and hyperammonemia are the common features, except arteriosuccinic acidemia, which has a trichorexis nodosa. It's a specific feature of this disease. Then there are defects of proline, ornithine, arginine, glutamine, valine. Coming to maple syrup urine disease. So this is basically because of defect in branch in keto acid dehydrogenase. There can be defect in even alpha, even beta, E2 deficiency. The characteristic feature of this disease is that there is a maple syrup odor in their urine and in their secretions. Then coming to leucine defects, isovaleric acidemia presents with sweaty feet odor, and 3-methyl-crotonyl glycinuria presents with cat's urine odor. So it is difficult to remember all these findings from these tables. That's why I have made a separate table for you people to see what to remember. Now, first of all, I would like you to remember that most of all of these diseases are actually autosomal recessive, except Hawkinsinuria, which is autosomal dominant, and it is because of defect in 4-hydroxyphenylpyruvate dioxygenase. And there are 3 diseases which are actually X-linked, including ocular albinism. It has caused it has many causes, including different enzymes or transporters. Then ornithine transcarbamylase deficiency is there. It is a classical, most common urea cycle defect because of defect in ornithine transcarbamylase. Then there is 2-methyl-3-hydroxybutyryl-CoA dehydrogenase deficiency. It is also X-linked. Okay. Then there are some odor are there, like phenylketonuria is associated with mousy odor. The effect is in phenylalanine hydroxylase enzyme. Tyrosinemia type 1 can have boiled cabbage odor, and it is because of fumarate acetoacetate hydrolase deficiency. Maple syrup urine disease, we have seen that because of branch and keto acid dehydrogenase deficiency, there is a maple syrup odor. 3-methyl-crotonyl glycinuria has cat's urine odor. Then glutaric acidemia type 2 and isovaleric acidemia both can have sweaty feet odor in them. So how these diseases generally present? So as we have already discussed that at one end of spectrum, we have conditions which are completely benign, like sarcosinemia. There can be a defect, but there is no any evident clinical manifestation. Or at one end, we can have completely lethal picture. Complete ornithine transcarbamylase deficiency is actually lethal. These infants won't survive only. But apart from having a manifestation between these two spectrums, one other problem is there that some diseases out of these may present very late during prolonged fasting or severe stress. So it is not necessary that a defect of amino acid presents since birth, and they can later on in their adult life can show manifestation of these diseases. So what are the other presentations? So common symptoms which are seen in 50% of patients of these diseases, they can present with severe dysfunction, development retardation, seizures, alterations in sensorium, or behavioral disturbances. Patients with classical urea cycle defects, they generally present with protein-induced vomiting. We know that when somebody eats protein, protein is metabolized to ammonia, ammonia is metabolized to urea in liver. So somebody's urea cycle is defective in the liver, they cannot handle protein. That's why when they ingest protein, they develop protein-induced vomiting. At the same time, they also develop urological dysfunctions and hyperammonemia. Organic acidemias generally present with metabolic ketoacidosis and high levels of hyperammonemia, and there can be sometimes focal tissue or organ involvement depending on the disease. There can be liver disease, renal failure, they can have some skin abnormalities, or they can have some ocular lesions. What are the common lab findings in these people? So generally, in these diseases, we go for a screening test and then we go for a confirmation test. Simple thing is, now we know there is a defect in amino acid handling. So what we can see, we can look for levels of these amino acids. They will be obviously increased. Or we can look for their secretion, excretion in the urine that we can see. So we can go either for serum level, plasma level, or we can go for urinary excretion. So generally, this plasma amino acids, when they are screened using ion exchange chromatography, liquid chromatography, and tandem mass spectrometry. And urine organic acids, as I discussed, that they increase in excretion can be checked with the help of gas chromatography or mass spectrometry. Then plasma acylcarnitine profile can also be seen in tandem mass spectrometry. Confirmation of these diseases will need a definitive assay. Either we can go with the enzyme assay that is performed on cells or tissue, or we can go for a definite genetic analysis. So now coming to hyperphenylalaninemia. Before going to further discussion of diseases, I would like you to show this slide and we'll try to understand the handling of phenylalanine in the body. So what happens? Dietary proteins, they are source of phenylalanine. Phenylalanine, when goes to body, it is metabolized to tyrosine with the help of some enzyme. And tyrosine is metabolized to dopa, and the melanin is formed. That's how the station is occurring. Suppose if there is block in this pathway from phenylalanine to tyrosine because of deficiency of phenylalanine hydroxylase that happens in phenylketonuria, then this metabolism, rather than going on this side, will go to this side. It will form phenylpyruvic acid and other substances which will lead to manifestations of phenylketonuria. Okay. Suppose if the enzyme which is converting tyrosine to dopa is defective here, tyrosinase enzyme and the other enzymes, then what will happen? Because we know that melanin is being formed from dopa and dopa is from tyrosine. That's how all tyrosinemias, they generally present with albinism. Tyrosine is also a precursor for tyrosine formation. When this is blocked, then tyrosine will not go to dopa formation. It will go to formation of para-hydroxy phenylpyruvate, then 2,5-dihydroxy phenylpyruvate, then homogentic acid. This pathway also generally occurs, and homogentic acid is actually handled with the help of oxidase enzyme. Suppose if this is blocked here, like for example in Alkaptonuria, then homogentic acid will increase in your blood. So this is simple diagrammatic representation of this thing. Let's see the complex thingy ones. So phenylalanine, when you're taking from protein from diet or endogenous proteins are broken down, then phenylalanine is there. It is then it can be converted to your tyrosine with the help of the phenyl hydroxylase. Then this tyrosine is going to pathway forming dopa, dopamine, noradrenaline. Dopa is forming dopaquinone with the help of tyrosinases, and then melanin is formed. And other handling of tyrosine is like toward para-hydroxyphenylpyruvate, homogentisate, then melyl esteroate, phenyl esteroate, fumarate, and esteroate. These are forming. So it is difficult to remember the exercise. You can stick to this figure, you can understand the basic concept, and then you can remember the defects which are associated with the diseases. So coming to phenylketonuria. Phenylketonuria basically is an autosomal recessive disorder. It is associated with increased concentration of phenylalanine and its byproducts. And these patients of phenylketonuria, they can present with severe intellectual disability in infancy if they are left untreated. And this disease is associated with reduced activity of phenylalanine hydroxylase. This is the first enzyme in the metabolism of phenylalanine. That phenylalanine inhibits transport of other amino acids required for protein or neurotransmitter synthesis, reduces synthesis, and increases degradation of myelin. So basically, what happens, apart from that, all products which are being formed for phenylalanine, they will not form, as well as this phenylalanine will inhibit the transport of other amino acids and also will degrade the myelin. And because we know, as we have seen, that this is important for formation of multiple neurotransmitters, there will be inadequate formation of norepinephrine and serotonin. And phenylalanine is actually a competitive inhibitor of tyrosinase. When this level of phenylalanine is increased, it will lead to your disruption of melanin synthesis. So these patients will also have reduced pigmentation, will lead to hyperpigmentation of hair and skin. Coming to the clinical features, so generally they are normal at birth. That may help to differentiate them from some genetic disease associated with mental abnormalities or abnormalities. So untreated children with classic phenylketonuria, they are generally normal at birth, and they fail to attain early development milestones. They can also have some microcephaly. They can have progressive impairment of cerebral function. They can have some hyperactivity, seizures, severe intellectual disability, and they can have some EEG abnormalities. And when you smell them, they can have mousy odor in their skin, their hair, and their urine due to phenyl acetate accumulation. This phenyl acetate will increase when this phenyl and hydroxylase will not work, and because of this phenyl acetate only, these patients will have mousy odor of skin, hair, and urine. And because as we have seen, there is reduced formation of pigment in these patients, it will lead to hyperpigmentation. They can also develop recurrent eczema of the skin. As far as treatment is concerned, dietary therapy, if you are at all start less than 2 weeks of age, because after 2 weeks of age, it will start hampering the CNS development. Because this disease is completely preventable if we start early in the infancy period. That's why America, Europe, and Australia, there is a neonatal screening program for these patients. And in these patients, generally, blood phenylalanine levels is more than your it's more. If suppose the level is more than 6 milligram per deciliter, then dietary restriction has to be advised. So phenylalanine restricted diet supplemented with tyrosine has to be given, because what happens, if we see, we know that phenylalanine is a precursor for tyrosine formation. So suppose if you are restricting a diet for phenylalanine, then in such condition, tyrosine also becomes essential. So patients will be given a phenylalanine restricted diet, but that diet should have supplemented with tyrosine. Target level that we want to keep it 2 to 6 milligram per deciliter. And in cases of milder diseases, this tetrahydrobaptrin can be given. It actually works as a cofactor for phenyl hydroxylase. In case of leaky defects, milder disease when is there, if you provide this tetrahydrobaptrin in doses of 5 to 20 g per kg per day, then probably it can increase the enzymatic activity of phenyl hydroxylase and can lead to some resolution of the deficiency. Maternal phenylketonuria. So basically what happens, many patients with many females with phenylketonuria, they can conceive and they can become pregnant, and then if their levels of this phenylalanine will not be adequately controlled, then what can happen, their children can have increased risk of congenital defects and microcephaly. This is known as maternal phenylketonuria. And after birth, these children have severe intellectual disability and growth retardation. So whenever some female patient who has phenylketonuria and is pregnant, then their risk can be minimized by continuing lifelong phenylalanine restricted diets, and strict restriction of phenylalanine has to be started 2 months prior to conception and throughout the gestation period. So coming to alkaptonuria. So Alkaptonuria, the other name for Alkaptonuria is ochronosis. Ochronosis word has come from ochre, and ochre color is nothing but this is the color of the ochre. So what happens basically when this disease occurs and when there is deposition of some intermediate substances in the tissues, and when biopsy is done, then microscopically grossly, these pigmentation appears like ochre color. That's how the name ochronosis has come. So alkaptonuria is because of increased levels of alkapton, and ochronosis is because of the appearance of that pigmentation, that deposit pigmentation, it appears like ochre color. Okay, so before going further, let's see little bit of biochemistry involved. So tyrosine, which is formed from phenylalanine, with the help of tyrosine transferase, it is converted into 4-hydroxyphenylpyruvic acid. So generally, this 4-hydroxyphenylpyruvic acid will be converted with the help of dioxinase into this homogentic acid. And this homogentic acid is further handled by a dioxinase, which will lead to formation of mallyl acetoacetic acid, and it will go to citric acid cycle. This is how this tyrosine is handled. Suppose if this enzyme is defective, as we can see in alkaptonuria, this homogentisate 1,2-dioxinase is, or you can simply say homogentisate oxygenase is not working, then rather than going to this pathway, this homogentic acid will go to this pathway with the help of polyphenol oxidase. So what happens once this homogentic acid is acted upon by polyphenol oxidase, there is formation of benzoquinone acetic acid, and then there are other formation of free radical formation of OH. All this will lead to additional tissue damage, and that cartilage destruction, everything will happen here, collagen destruction will happen. And here this benzoquinone acetic acid, it actually gets polymerized, and then it forms a melanin-like pigment. So this melanin-like pigment get deposited to tissues, and grossly when you see this melanin-like pigment actually appears with the ochre color. That's how the name ochronosis has come. So if you see this figure also is showing beautifully that people are giving nitisinone and ascorbic acid for treatment of your alkaptonuria. So you can see that nitisinone is actually inhibiting one enzyme prior to the defect in alkaptonuria, so that homogentic acid is not formed only. And ascorbic acid actually leading to inhibition of this enzyme polyphenol oxidase, because of which there will be reduced formation of benzoquinone acetic acid, as well as reduced formation of free radicals, reduced tissue injury. So what I want to tell that ascorbic acid can be helpful in milder cases or can be helpful up to some extent. Nitisinone has been tried in a trial, Sonia trial, and it has been found to be effective. And this homogentic acid, when accumulates, it also leads, apart from leading to this formation of pigment, when it comes out of urine, it also leads to blackening of urine. So alkaptonuria, ochronosis, rare disorder of tyrosine metabolism, frequency is very rare, 1 in 2 lakh cases. Deficiency of homogentisate 1,2-dioxinase, homogentic acid oxidase, and in this disease there is accretion of large amount of homogentic acid in urine, and there can be accumulation of oxidized homogentic acid pigment in connective tissue. That's how the name ochronosis has come. Clinically, what can happen when defect is mild? Many of these patients, they can go unrecognized until middle life. And at that time, they generally present with musculoskeletal complaint with degenerative joint disease. 50% of patients, they have this presence of urine that become dark with standing or addition of alkali. So when these patients, they pass urine in the open, after some time, because of action by the oxygen in the air, their urine turns black because of oxidization of homogentic acid. After 30 years of age, these patients generally present with foci of gray-brown scleral pigments, generally darkening of the concha, antihelix, and finally helix the ear. And they can present with degenerative spinal disease with low back pain that usually starts between 30 and 40 years of age. So why symptoms appear late in these patients, musculoskeletal symptoms. So what happens? Homogentic acid usually it is excreted through kidney, and as aging occurs, that clearance reduces, and then deposition start and symptom appears. So that's how when defect is milder, it is going to be unnoticed in the first 3 decades of life, but later on, as EGFR reduces, this clearance reduces, and because of that, this pigment starts depositing in tissues. Once it has deposited in substantial amount, then pigmentation will start. So this is a picture patient of achronosis, Alkaptonuria. We can see that there is ear cartilage, all this thing, anti-helix and concha part, every part is showing this pigmentation. Pigmentation in the skin generally appears like bluish grayish, slate gray type. And we also can see that both the sclera, there is pigmentation because of deposition of homogentic acid in this patient. Occlusive arthritis patient generally present with pain, stiffness. There will be some limitation of motion of the hips, knee, and shoulders. And in some cases, it may resemble like rheumatoid arthritis, but in general, small joints are usually spared, and hip, knee, and shoulder, these bigger joints are involved. So there can be also pigmentation of heart valves, larynx, tympanic membrane, skin. There can be presence of pigmented renal or prostatic calculi. So this pigment deposition, when it occurs in hardened blood vessel, subsequently it can lead to aortic stenosis, and there can be need of valve replacement in the patient, generally around 60 years of age. So in this figure, we can see that all these calculi have been extracted from a achronosis patient, and all these are pigmented because of presence of homogentic acid. So generally, patients of Alkaptonuria, they present with a triad of dark urine, pigmentation, and arthritis. This dark urine, 25% patient not at all will show any darkening of urine. The reason for that thing is not known. Pigmentation, as we have seen in the skin or in the sclera or in the ear cartilage, can be seen. Then arthritis can be there, as we have discussed already. Arthritis completely non-inflammatory. When there is involvement of spine, there is a mechanical back pain, and they can present with wafer-like discalcification and very small or no osteophytes. These findings actually can help you differentiate changes of achronosis from changes of OA or changes of spondyloarthritis. And large joints can be involved like knee, ankle, and shoulder, and they can present like OA-like changes. So this figure, you can see that there is a wafer-like calcification of these intervertebral disc, and formation of these small osteophytes are there. They are not very big, chunky, as we see in osteoarthritis and other diseases. So these findings are typically seen in case of your Alkaptonuria. As far treatment is concerned, so before treatment, we need to confirm diagnosis. Generally, clinical history sufficient to suggest possibility of Alkaptonuria, or we can go for seeing blackening of urine. 10 drops of 10% sodium hydroxide in 20 ml of urine. This is the standard protocol that is being used. Then we can look for the presence of rate of excretion of homogentic acid. So it is generally 0.03 millimole per milliliter of creatinine till 7 years of age, and after that it becomes more than 0.017 millimole per millimole of creatinine. Then we can order some X-ray which can show degenerative changes. There is in blood we can see reduced MMP mediated choline type 2 degradation. It is actually increase in OA, but it is reduced in case of your Alkaptonuria. So in patients where you're confused whether this is really achronotic changes or this is like osteoarthritis, you can look for the MMP mediated choline type 2 degradation, which will be low in case of your achronosis. This is a picture showing the clear urine, and this has become dark after adding 10 drops of 10% of sodium hydroxide. It leads to faster oxidation of urine, leading to darkening of the urine. So for ochronotic arthritis, what we do generally, because we know there is no ongoing inflammation, we give symptomatic treatment with pain medications. Patients having significant spine disease can undergo spinal surgeries. Then patients having so much joint involvement can undergo arthroplasty. And as we have seen that figure, that ascorbic acid can actually reduce formation of harmful end products, but ascorbic acid in protein restrictions has not been found effective in reducing homogenetic acid levels. And nitisinone, this drug has been tried. It reduces urinary excretion of homogenetic acid, and it also prevents further tissue damage. This drug has been tried in a trial SONIA 1 in patients of Alkaptonuria, and it is found to be effective. In conjunction with low protein diet, this drug might prevent long-term complication of Alkaptonuria. So coming to homocysteinurias, before going to homocysteinurias, let's understand this figure. It appears quite complicated, but what I want you to focus on homocysteine here. Okay, so what we know that homocysteine is converted to methionine with the help of these intermediates methyl tetrahydrofolate, which provides its methyl group to cobalamin to form methylcobalamin. Once methylcobalamin is formed, methylcobalamin will provide its methyl to homocysteine, and that's how it will be converted to methionine. Okay, so in this reaction, at one side, this homocysteine is being converted to methionine. At one side, methylcobalamin will be converted to your cobalamin, and at one side, this methyl tetrahydrofolate will be converted to tetrahydrofolate. This is gonna happen. So what happens once this methionine is formed? Then it will go form acetylmethionine, then again acetylhomocysteine, and then this methyl will go. So basically, just to provide one methyl group, there are so many people are involved. So this reaction is important because whatever methylation reactions are occurring in body, in all those reactions, most of the reaction, this step is required. So now what happens? Suppose if there is this homocysteine is actually with the help of cystathionine beta synthase, which is a vitamin B6 dependent reaction. Homocysteine along with serine will be converted to cystathionine. Suppose if there is defect in this cystathionine beta synthase, then also homocysteine will increase. There is defect in availability of this thing or availability of this thing, or there is defect somewhere here, and if there is so much of methionine, then also it convert back to homocysteine. So whenever there is increase in this, whenever there is a non-availability of this thing or defect in this enzyme, all will lead to high levels of homocysteine. So there can be conditions which are associated inheritedly, genetically with homocystinemia, and there can be acquired defects. For example, deficiency of this vitamin B12 also can lead to homocysteine high levels. Deficiency of folate can also lead to high levels of homocysteine. Okay. Apart from that, realize, so what happens? This methyl tetrahydrofolate actually provides its methyl moiety to cobalamin to form methylcobalamin. Then this methylcobalamin provides its methyl moiety to homocysteine to form methionine, right? Suppose if there is deficiency of cobalamin, like vitamin B12 is deficient. If vitamin B12 is deficient, then this methyl tetrahydrofolate has no one to accept its methyl. Once it happens, then all the folate in the body will be in the form of methyl tetrahydrofolate. Once it happens, then because this has happened and this is not forming, this methyl tetrahydrofolate cannot be converted back to tetrahydrofolate. So all the methyl, all the folate will be accumulated in this form. And remember that this tetrahydrofolate is required for the formation of DNA. So what happens? Although there is deficiency of cobalamin in the body, but because of cobalamin deficiency, all the folate has been into methyl tetrahydrofolate form, trapped, and there is no availability of tetrahydrofolate. So this is known as folate trap. So now this folate is there in the body, but all converted into methyl tetrahydrofolate, and which is not useful for further DNA synthesis. So what we can say that when cobalamin deficiency is there is a functional deficiency of tetrahydrofolate also. This is known as folate trap. So coming to homocystinuria, as we discussed at the beginning of the presentation, there are different 9 kinds of homocystinuria forms. Classic homocystinuria is because of cystathionine beta synthase, And these patients, they present with lens dislocation, thrombotic vascular diseases, increased disabilities, osteoporosis, and Marfan-like habitus. Apart from that, we have 5,10 methylene tetrahydrofolate deficiency. So let's see these defects in the figure. As we can see, cystine beta synthesis here. So if it is defective, obviously homocysteine level will increase. Then 5,10 methylene tetrahydrofolate deficiency. Let's see what happens. So this is the enzyme they're talking about. If this enzyme is defective, then there will be less availability of this substrate. And this is actually required for conversion of homocysteine to methionine. So in this defect also, there will be high levels of homocysteine. Coming to methionine synthase, so let's see where is methionine synthase. So methionine synthase is the enzyme which is involved in formation of homocysteine to methionine. So if methionine synthase is defective, then also homocysteine level will increase. Now coming to other causes like vitamin B12, lysosomal efflux and metabolism, all these proteins are there. So all these proteins are here, which are actually involved in availability of methylcobalamin. So methylcobalamin will not form. So these other diseases are actually less common. Most common form is homocystinuria because of cystathionine beta synthase deficiency. Okay, so homocystinias are 9 biochemically clinically distinct disorders. There is increased concentration of the sulfur-containing amino acids, that is homocysteine in the blood and urine. So now coming to classic homocystinuria, it is the most common form and frequency is 1 in 4 lakh of persons. There is reduced activity of cystathionine beta synthase because of that there is increased homocysteine level. And this enzyme is actually pyridoxal phosphate dependent, vitamin B6 dependent, and it condenses homocysteine with serine to form cystathionine. Most patients of homocystinuria, they present between 3 and 5 years of age. They present generally with dislocated optic lenses. 50% of people can have some intellectual disability. They can have Marfan habitus, and they can have radiological evidence of osteoporosis. Complications, they may have life-threatening complications, like they can have vascular complications affecting coronary arteries, general arteries, and cerebral arteries. Generally, all these events will present first decade of life. Therefore, any person with Marfan-like habitus with the dislocated lens presenting with coronary artery disease in very earlier phase, then homocysteine is suspected. And these causes are the main cause of morbidity and mortality. Coming to management, diagnosis you can make with the help of analysis of plasma homocysteine levels. Obviously, they will have elevated methionine and presence of free homocysteine. They will have high levels of total plasma homocysteine levels. Usually, it is more than 100 micromole in these patients. Treatment, let's see, basically aim of treatment is to prevent complications, and these modalities have been used. They can be provided with special diet that is restricted in protein and methionine. They can be provided oral pyridoxine, that is vitamin B6. As we have seen, cystathionine beta synthase is a pyridoxine dependent enzyme. Probably in leaky defects or milder defects, providing this pyridoxine might improve condition to some extent. Oral pyridoxine can be given 25 to 500 mg per day. Then folate and B12 should be supplemented in these patients. And this betaine, which is actually a cofactor for the reaction from homocysteine to methionine, can also be given 3 grams twice a day to increase the activity of the enzyme. Other forms of homocystinuria, in other forms of homocystinuria, there is an impaired remethylation of homocysteine to methionine. It can be caused by either defective methionine synthase enzyme, or there can be deficiency of 5-methyl tetrahydrofolate deficiency, or there can be methylcobalamin deficiency. So in contrast to classical form, which has cystathionine beta synthase deficiency, in these disorders, elevated level of homocysteine is associated with low levels of methionine in the plasma amino acid profile in these diseases. So what happens basically, now you see all these 3 reactions are responsible for the substrate which will be utilized for formation of methionine. So when in these defects, generally there is low levels of methionine, while in classic homocystinuria, there is high level of methionine. This is one way how you can differentiate between classical and non-classical homocystinuria. Treatment is same as there is for classical homocystinuria. Coming to hyperhomocysteinemias, so basically what can happen, there can be increased total plasma concentration of homocysteine with or without an increase in free homocysteine disulfide form. So this is known as hyperhomocysteinemia. Hypercystinuria in the absence of significant homocystinuria can be seen in some patients who are heterozygous for the defects of genetic defect, or they can be seen in milder variants of homozygotes. Now, we all have seen in our ward that these patients of homocystinuria, they can have high levels of atherosclerotic disease, they can have thrombus formation, arterial as well as venous. So we tend to send workup for these patients to look for homocysteine level. We should always remember that when we are sending homocysteine level, we should also notice about the secondary cause of high levels of homocysteine. So these are some important causes in clinical setting which can also lead to high levels of homocysteine. These include increasing age, postmenopausal women, then smoking also increases your homocysteine levels, renal failure, psoriasis, inflammatory bowel disease, leukemias, hypothyroidism, and there are some drugs which can lead to increased level of homocysteine, including methotrexate, nitrous oxide, isoniazid, and many antiepileptic agents. So whenever you are ordering homocysteine levels for any patient in clinical setting, try to see for these confounding factors. So long-term complications, as we discussed, coronary artery disease, cerebrovascular disease, peripheral vascular disease, deep vein thrombosis, and as we know, because of folate deficiency and B12 deficiency, there is neural defects. So there can be neural tube defects in your homocysteinemias. Then dementia, Alzheimer's disease patient also have to be found high levels of homocystinuria. Coming to urea cycle defect and the last topic of discussion. Before going further, I would like to show you this figure from Harper's Biochemistry. This is simplified version. Then we will discuss about the Harrison figure. Let's see first figure from Harper. So this figure is showing urea cycle. This structure is nothing but the mitochondria, and this part is cytoplasm. So basically, they are trying to show what reactions are occurring in mitochondria and what reactions are occurring in your cytoplasm. So let's start from 1, 2, 3, 4, and 5. So what happens in the beginning? Ammonia is formed from protein. It is formed from protein, and liver is the place where the cycle is happening. So in liver, when protein handling is occurring, then ammonia is being produced, and this ammonia is actually entering mitochondria, and with the help of this enzyme carbamyl phosphate synthase 1 CPS1, carbon dioxide also taken, CO2 and ammonia, they will be utilized with the help of this enzyme. Then ATP molecules will be involved, the formation of carbamyl phosphate. So once this carbon phosphate is formed, then with the help of this enzyme, which is ornithine transcarbamylase, or also known as OTC, this will bind ornithine with this carbamyl phosphate, and it will lead to formation of citrulline. Once citrulline is formed, citrulline is transported outside mitochondria, it comes to cytoplasm. Once citrulline is in the cytoplasm, and then what happens? Citrulline is acted upon by arginine synthase, and with the help of this thing, aspartate will be utilized in this reaction. Citrulline and aspartate will bind, and they will form arginine. This is cleared with the help of arginine, leading to release of fumarate, formation of arginine. Then arginine is acted upon by arginase, which will lead to release of urea, and then ornithine will be left. Ornithine will enter again your mitochondria and will bind with the new molecule of carbon phosphate. So this is the reaction. This is cycle, your cycle. Now understand this. Suppose if there is defect in this enzyme, or somewhere defect is there, then obviously citrulline will not form, right? Citrulline level will low. But if defect in this enzyme, then your citrulline level will be high. Generally, if defect is there in this enzyme, or this enzyme, there is low level of arginine. But if defect is in arginine enzyme, then this is the nearest substrate. So level of arginine will be very high. Why I'm telling you this? Because when you work up your patients for defects of your cycle, you tend to see the levels of different metabolites, and you see which all are low, which all are high. They can give rough idea about the particular enzyme which is defective in the patient. Okay, now coming to diagram from Harris. So this is same thing, only little easier actually. So we can see that we have N-acetyl glutamate synthase. N-acetyl glutamate synthase is actually forming your N-acetyl glutamate with the help of acetyl CoA, and glutamate is being combined with the help of this NAG synthase, and this is forming. Here what we can see, carbon dioxide, water, and they, with the help of carbonic anhydrase 5A, these are converted into bicarbonic acid, ammonia, and two ATIC molecules are used. And with the help of CPS1, that is carbonyl phosphate synthase 1, carbonyl phosphate is formed. So this is that first reaction that we have seen here. This reaction only which is happening. Now what happens once this carbonyl phosphate is formed, then ornithine, which was released from the molecule of arginine, then these two will bind. It will form citrulline. Citrulline will be transported out of mitochondria. It will came out, then subsequently it will enter the reaction. And when the reaction is finished, urea is released. Then again this arginine converted into urea and ornithine. Ornithine will enter the mitochondria again with the help of ornithine transporter 1. Okay. This carbonyl phosphate, actually, when not binding ornithine, if it increases concentration, it can go out of mitochondria. It can be converted to orotic acid, and then subsequently can be converted to UTP and CTP. So let's see what are these cycle defects. So there can be complete absence of these any of the enzyme of this cycle, and when it happens, generally these diseases they present like severe hyperammonemia in newborns, or in adults there can be milder variants can be seen. So the basic defect is that because of no handling of ammonia, there is accumulation of ammonia and glutamine, and there can be direct neurotoxicity and brain edema. So remember, glutamic acid and glutamine, when glutamic acid binds with one more ammonia, it forms glutamine. This is the reason, because body is having hyperammonemia, body is trying to reduce it. So what does body do? Glutamic acid will bind to ammonia and form glutamine, and that's how, apart from high levels of ammonia, there are high levels of glutamine in the body in case of urea cycle defect. So individually, these diseases are rare, but as a group, 1 in 35,000 individuals can be affected. And all diseases are autosomal recessive with exception of ornithine transcarbonyl deficiency, which is X-linked. And in fact, this ornithine transcarbamylase deficiency is the most common urea cycle defect. So clinical presentation. So infants generally present with 1 to 4 days of life with refusal to eat lethargy, and when they are fed, they can progress to coma and death. Then milder enzyme deficiencies generally present with protein avoidance, recurrent vomiting, migraine, mood swings, chronic fatigue, irritability, disorientation that could progress to coma. Some cases presents with acute or chronic hepatic dysfunction. And although we know that this ornithine transcarbamylase deficiency is X-linked, but some females with deficiency can present at the time of childbirth due to involuntary fasting and stress that favors catabolism. They can have other presentation. Patients of urea cycle defect can have precipitated hyperammonemia when they are given steroids. It can be fatal. And these patients can also present with non-specific symptoms and can be misdiagnosed as having GI disorders, food allergies, behavioral problems, and non-specific hepatitis. So in all the cases, if proper history is taken, there can always be seen an association between protein intake and the symptoms of the patient. Okay, so as I discussed in that figure, that if you see what defect is present, you can always see that before defect and after defect. If you can check the level of the molecules, their concentration, you will be able to pinpoint the enzyme which is involved. So suppose if you are having increased glutamine. So as we discussed, increased glutamine is seen with all the conditions of urea cycle defects. So this is because ammonia is not removed by the cycle, and in liver cells, this glutamate is conjugated to ammonia to form more levels of glutamine. Then we can see very low citrulline levels when there are proximal defects of the urea cycle, as there can be deficiency of NAG synthase deficiency, CPT1 deficiency, or ornithine transcarbon deficiency. In these patients, citrulline will not form only. That's why they will have low citrulline levels. High uric acid can be seen in case of only ornithine transcarbonylase deficiency. Very high plasma citrulline level is generally seen in case of your arginine acid deficiency, because this enzyme is just distal to citrulline. So if it is not there, citrulline is accumulated. Then mild elevation of plasma citrulline with the presence of arginine acid urea is seen in case of your arginine acid lyase deficiency. Then high arginine level, otherwise not seen in the condition, but can be seen in arginine deficiency. So if somebody is suspected of urea cycle defect and you check for levels of glutamine, citrulline, orotic acid, or let's say your arginine, you may be able to pinpoint the enzyme which is actually defective. Urea cycle defects are not the only cause which are causing hyperammonemia. There can be other conditions like liver disease from any cause can lead to hyperammonemia because it will reduce the capacity of liver to handle the protein load. Then there are several organic acidemias apart from these defects. For that thing, you need to check their urine organic acid levels, and fatty acid oxidation defects also lead to your amino acid hyperammonemia. So for that thing, you need to check for plasma acylcarnitine profile. Treatment. So aim of treatment is basically stopping catabolism and ammonia production by providing adequate calories. So these patients are given IV glucose and lipids in the comatose patients. Then excess nitrogen has to be removed. So IV phenyl acetate and benzoate can be given 0.25 gram per kg priming dose and subsequently as infusion of 24 hours. So basically what happens, this IV phenyl acetate and benzoate will conjugate glutamine and glycine, and they will form phenyl acetyl glutamine and hippuric acid, and both these substances are water soluble molecule which can effectively excreted in the urine. Then apart from that, you can provide arginine to these patients because once there is defect in the cycle, arginine will not form only, and in such condition it becomes an essential amino acid. 200 mg per kg per day IV has to be given. It becomes essential, except in arginine deficiency, other enzyme defect, it has to be supplemented. Then suppose if everything is failed and not responding, then you can go for a hemodialysis to remove excess of ammonia. Then chronic therapy for this patient, you have to provide protein restricted diet, phenylbutyrate, glycerol, arginine, or citrulline supplements, depending on what enzyme is effective and what levels are of these things in the blood. And then oral carglumic acid has been tried because it restores a functional cycle in patient with N-acetyl glutamate synthase deficiency. And in long term, if patient is stable, you can think of liver transplantation. So other causes of hyperammonemia, there can be hyperammonemia due to functional deficiency of glutamine synthase, which can happen. So this glutamine synthase deficiency occurs in patients receiving chemotherapy for different malignancies undergoing solid organ transplant. So many patients of chemotherapy organ transplant, they can have hyperammonemia because of functional deficiency of glutamine synthase, or in the condition when the liver is cirrhotic, they can also have hyperammonemia. And for these two conditions also, all the protocols that we discussed last slide have been tried with some success. So here we end the discussion, and now we come to our basic problems again. So let's discuss problem number 1. If someone is on phenylalanine restricted diet, then which amino acid becomes essential? Answer is tyrosine. As we have seen in the discussion, that phenylalanine will further metabolize and it will be the precursor for tyrosine. Suppose somebody has to be given phenylalanine restricted diet, then they should be supplemented with tyrosine. This happens particularly in cases of phenylketonuria. Classic urea cycle defects are associated with the increased plasma level of glutamine. So what we discussed, the glutamate is there, it is conjugated with excess ammonia, forming a amine form itself that is known as glutamine. So this glutamine levels are generally high in all types of urea cycle defects. Folate trap means that folate also becomes deficient when B12 is deficient. Because B12 is deficient, then methyl tetrahydrofolate will not be converted to tetrahydrofolate, and the DNA synthesis will be affected. So this is known as folate trap. Then previously completely healthy 30 years old male had 2 discrete episodes of acute onset coma with hyperammonemia and red plasma glutamine levels. The first time he had steak and second time he had fish prior to the episode. His father and one paternal uncle also have a history of similar kind of illness, but they both died of liver failure. So most likely he has ornithine transcarbamylase deficiency. There are 2 hints in this question. First hint was that only males are being affected with the condition, and second hint was that both time he had taken a high protein load. So this typically happens in case of your urea cycle defect. As such, also your OTC deficiency is the most common defect. So these are the answers to your problem. I hope this class has been helpful to people. If there are any further queries and questions that can be sent to me, I would try to answer for your doubts. Thank you.